Good evening, doctors. I'm Vinita Gaur, the head of marketing for Merck. Before we start with the scientific program, I would like to take this privilege of firstly welcoming each one of you for today's international speaker program along with Dr. Ricardo. In addition to that, as we know, in India, we start any auspicious thing by lighting of the lamp. So, may I have the privilege of calling upon our esteemed experts who are going to help us to drive the scientific session today. May I call upon Dr. YVCR Reddy? May I call upon Professor Ricardo to please step forward, Dr. D. Prabhakaran and Dr. Hari Krishnan to please come forward, along with the head of the entire South from Merck, Raghavan G, to please step forward. Can I have Bhuvna and also Hari to please come forward, along with Dr. Harshal to please come forward for the lighting of the lamp.
वक्रतुंड महाकाय सूर्यकोटि सम वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
Merck, पहले ही हो गया, बिफोर हैंड हो गया. Merck.
This is life. Come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we?
Good evening, doctors. I am Vinita Gaur. I head the marketing for cardiovascular business for Merck. It's my privilege to thank each one of you to join us today evening, both live and through the telecast, telecast centers across India. More than 35 locations. We have a hybrid program today and expecting more than 2,000 clinicians to join live for today's program. At Merck, we truly believe that patients are the center of our work, and we believe in coming up with the distinguished scientific programs which has a mix of both experience and evidence. I'm really excited for today's evening, but before we get into the scientific proceedings, may I take upon a couple of minutes to talk about my company, Merck. So at Merck, as we say, who we are a vibrant science and technology-driven company. Science is at the heart of each and everything that we do. We at Merck, across various countries, more than 56,000 employees work day in and day out to make positive difference to multiple lives. I would like to add upon that we believe that patients are the center of our work, and our portfolio addresses to various therapeutic areas, which includes oncology, immunology, general medicine, endocrinology, neurology, immunology, and fertility. What makes us happy is that every single day, more than 72 million patients worldwide consumes the drugs and medicine of Merck. It could not have been possible without the support and the trust that has been rendered by clinicians across India to help us make the brands and the services for Merck popular all over India. Since we are talking about Merck, how can we not mention that Merck is the oldest pharmaceutical company, and though we still like to call us young, we are 355-year-old or young company. Today, we are conducting the scientific program with CM Care, which has the research brand, the flagship brand and the originator brand of bisoprolol, Concor. We do have Concor AM, and recently we had introduced Concor T, low dose, Euthyrox, Carbophage, Libico, Starvogue, and also Elmighty. And something that we are always happy to talk about from the heart, very, very sincerely welcoming each one of you to the world of Concor, the world full of passion, and as we say, a small pill with a very big heart since 1986. Yes, talking about the research brand, the originator brand Concor, I would like to add upon that today we are available in more than 120 countries and being consumed by more than 20 million patients. But coming back to our home country, which is India, and yes, a matter of pride that trust that we have got over the years had made Concor the #1 brand across India. What makes us happy, while there are choices of various beta blocker, today we see in last 2 to 3 years, bisoprolol has become the second largest molecule in India, while Concor continues to be the #1 brand. And when we talk about the recent publication in the Indian Heart Journal, bisoprolol remains the most commonly prescribed antihypertensive drug. This has happened all because of the trust. And today, every third patient who has a beta blocker, it is Concor. So thank you, doctors across India, across the globe for supporting us. And further to that, I would like to add upon that bisoprolol in India has become the preferred choice among all Indian clinicians, and of course, very much liked by the patients, widely used in the real world evidence. Across CV continuum, there is good usage that we are seeing day by day, and it is recommended by guidelines and evidence. Last not the least, at the end of the day, we work for patients. We want better health of the patients. With every passing minutes, there is more than 1,100 patients who are consuming Concor. So thank you from the bottom of my heart again for ensuring that the best quality medicine from Merck is being served to so many patients across in India. Further to that, since all our medical programs is directed to get more and more insights from each one of you, we have been given the suggestion of coming up with one of the most wonderful combination. It is the world's number one beta blocker Concor, along with the number one ARV, which is Telmisartan. And it's been 3 years of Concor T launch. I would like to just mention that in India, Concor T is the reigning leader. And thanks for all your support. In addition to that, the last slide before I get into the scientific proceedings is that today we have expanded, and there are more than 500 colleagues all over India through two teams as promoting the basket of Merck product, starting with the Concor Core, having Concor, Concor Core, Euthyrox, low dose, and Concor Plus, and CMNE EGM team promoting Concor T, Concor AM, Almighty, Lipigo, Carbopharge, and Staro. With this, I will invite Dr. Harshal, our medical director, to please take the medical proceedings further. Thank you all, and I hope that all of us will have a very exciting and enriching session. Thank you.
राइट क्लिक करो exit. रिज्यूम कर लो ना रिज्यूम. Please. Where is this slide? I need you. So, very good evening, all the respected doctors. First of all, thank you so much for joining us. And I'm very happy and very pleased to, introduce our esteemed faculty today. Today's faculty is nationally and internationally renowned faculty that we have, and we don't require much of an introduction. Enormous work they have done in the field of cardiology. We have Dr. YVC Reddy sir, who is a senior consultant interventional cardiologist at Apollo Hospital, Chennai. And he has been having lot of publication, lot of procedures he has done. Like we have British Commonwealth scholar in interventional cardiology at University Hospitals, Wales, UK, high volume interventional cardiology, almost 18,000 procedures he has done, plus 2,900 plus PCIs. His expertise in complex coronary interventionals, including left main PCI and so on and so forth. Welcome, sir. We have Dr. Ricardo Fontes Carvalho. He's coming from Portugal, and he also attended ACC Congress and bringing a lot of insights from ACC on beta blockers perspective. Welcome, Professor. He's a Director, Cardiology Department, Local Health Unit, Gaia and Epsino, Portugal. He's a full professor of Faculty of Medicine, University of Porto, and he's a specialist in cardiac imaging and clinical cardiology. With extensive involvement in cardiovascular research, more than 50 clinical trials. The author of over 200 peer-reviewed publications, he has delivered more than 300 talks, and active contributor to many of the societies. He is the Vice President of Portuguese Society of Cardiology and the immediate past governor of the ACC as well, Portugal chapter. So welcome, Professor. We have our Indian speaker to deliver talk on how CV disease is different, and Dr. Prabhakar Dorairaj sir, welcome. He's a senior consultant interventional cardiologist at Ashwin Clinic, Chennai, and many accolades, achievements. Sir has preventive interventional cardiologist with a special interest in preventive cardiology, dyslipidemia. Is a founder member of ACERT. Is the author of more than 25 publications and many international presentations. He has been the faculty at global level. So welcome, sir. At the same time, we have a panelist, esteemed panelist, Dr. Harikrishna Parthasarthi sir, who is a senior consultant interventional cardiologist, Apollo Specialty Hospital, Vanagram, Chennai, and many more associations in Chennai. He has extensive expertise in the complex coronary interventions and including primary PCI and so on and so forth. Performed more than 300 procedures, founder and course director of major cardiology academic initiatives and national faculty and international faculty at multiple level, and one of the TAVI experts in India. So with that, we have this event broadcasted almost across India at 37 centers, and these are all the esteemed faculties at that individual centers. Just to introduce very quickly, Dr. Shailesh Zayade sir from Amravati, Dr. Ravindra Ghongde from Karad, Dr. Prashant Madharia, Raipur. We have other doctors as well at the same time. We have Dr. Krishnakant Sharma from Bhavnagar, Dr. Sunil Kumar Karna, Anand, Dr. Swapnil Punekar from Chandrapur, and many other doctors at the same time. Dr. Shital Kumar Gatagat from Latur, Dr. Naresh Midha from Jodhpur, Dr. C.P. Purohit from Udaipur, Dr. M.D. Hamid Ali from Barhampur, Dr. Pranjit Mushari from Guwahati, Dr. Indra Kuladhipati from Guwahati, Dr. P.C. Runu from Ranchi, Dr. Shahid Parvez from Dhanbad, and Dr. Anshu Agarwal from Muzaffarnagar. We have Dr. Abdul Hafiz from Gulbarga, Dr. Jaishilan from Mysore, Dr. Jayandhala from Bhimavaram. And that's it, all our introduction of the whole of the faculties. So may I request now our moderator of the day, Dr. YVC Reddy sir, to start his opening remarks and further proceedings. So over to you, sir.
Thank you, Harshal. Welcome you all. It's my privilege to drive today's summit on beta blockers reappraisal, where we stand in 2026. We all use these drugs day in and day out. So what we're going to focus today on the 3 M's, the myth, the magic and the marvel. The myth is about beta blockers being as a single homogeneous group of drugs. It's not. They're as distinct as the areas in our country. All beta blockers are not the same, and Dr. Ricardo is going to highlight that aspect of the myth aspect of that beta blockers. About the magic, somehow, some of these beta blockers, especially, for example, I love bisoprolol, and we were talking to Professor Ricardo as well. Why these beta blockers are so useful across the entire cardiovascular spectrum, be it a simple CAD, angina, MI, LV dysfunction, heart failure, arrhythmias, hypertension. There is a gamut of cardiovascular spectrum of disorders where they seem to reign supreme with good end points as well, hard end points, MACE reductions and all that. So we'll see what the magic is involved in this. And finally, the marvel. Why this one drug, bisoprolol, is a marvel. There are some biochemical and pharmacological properties which make it the supreme beta blocker, and we're going to discuss that. This is about the three issues which are going to do today. We have the first talk by Dr. Prabhakar, is going to talk about the cardiovascular disease, the difference, how it is different from what is seen in the West, and then followed by Professor Ricardo's interesting talk. Over to you, Prabhakar.
Is it sharing? Is it screen sharing or not? It's not sharing. Reshare it now. Close this. Reshare. Yeah, just reshare it. No, it's in presentation mode. Good evening, everybody. I think I'll not waste much time between you and Professor Ricardo. I think all of us are keen on listening to Professor Ricardo. There is an audio going on somewhere here. Can somebody cut off the audio here? There's some. I can listen to myself speaking. Probably. Thanks. Yeah. So what I shall be doing over the next, first, let me thank Merck for giving an opportunity for this wonderful interaction with Professor Ricardo today evening and all the people who have joined us today. I will be talking about are cardiovascular diseases different in India. So instead of giving you something the usual way, what I thought I'll do is I'll give you something about what is happening here. I'm not able to move the slide. So is there a way I can move this? Next is not working. Click is not working. Okay. It should work. Yeah, now it's working. Fine. Good. So what I shall be doing is I'll be giving my talk in three parts. This entire screen is gone. Okay. One is on hypertension, two on coronary artery disease, and third is on heart failure. Can you get it? No? It's going on and off. I think something is loose. I think it's good. It's good now. Okay? Fine. So one is on hypertension, coronary artery disease, and heart failure. And looking at the heart hypertension in India, the prevalence has been increasing over the years from 29%. The small drop in 2003, but now we stand at 33%. And we are expected to reach 44% by 2030. Now, we are talking about a conservative diagnosis of 140/90, not the 130/80. If you look at 130/80 for diagnosis, we are going to be talking about 50% straight away. We are not looking at that. And this is where hypertension stands today. Where does Tamil Nadu stand? We had a recent publication on more than 3 drugs for the control of hypertension. Me, Dr. Harikishan, were all part of this particular paper. And this is about how Tamil Nadu cardiologists treat more than 3 drugs for hypertension. We had 10 outpatient cardiology centers with about 420 patients, with the 64 of them diabetic, mean age was 65. The usage was very interesting. ARBs were used in 88%. Only 1% were on ACE inhibitors. The calcium channel blockers were used in 85%, diuretics in 82%, beta blockers beat them everybody and said 85% usage, much more than the MRA usage, which is supposed to be there, which is only 39%. Now, why this huge beta blocker usage among cardiologists in hypertension in India? One is the resting heart rates in India, according to the India Heart Study, are higher. Cardiologists seem to be preferring beta blockers quite a lot. rather than by going by the convention and saying after the third drug you start using MRA, cardiologists seem to be preferring beta blockers, and that is where we stand in hypertension today. And when I started looking at the drugs, this might interest Merck, who is talking about bisoprolol. In hypertension, it is predominantly metoprolol. The next is going to be very closely bisoprolol. Carvedilol and nebivolol are also being used for hypertension usage. Now, this is the pattern of usage of drugs among the cardiologists here. This is where India stands. And individual doses, we are using about 50 and 100 milligrams of metoprolol more often. The higher doses are used for hypertension, which is fair enough. Next, if you start looking at heart failure, we have conventionally used to talking about the 4 pillars of heart failure. What we did was we redefined heart failure and said, instead of using beta blockers alone, you can use beta blockers and ivabradine as part of the guideline. So we called it the practical guideline directed medical therapy, and we are actually in press. We are publishing this paper of our ACERT, or Associates of Cardiology Education Research in Tamil Nadu, chronic heart failure registry, which is actually in press in the Journal of Cardiac Failure. And we looked at 2,000 patients with chronic heart failure. Now, the beauty is that it is not acute heart failure. Patients should be on treatment for at least 2 months. The main reason for that is you give time to start GDMT. And when these patients were studied, we found out, we'll skip the baseline direct characteristics, 81% of patients are on beta blockers. We are very good there. But RNA usage is only 58%. But when you look at all RAS inhibitor users, we were 74%, 50% on MRAs, and 53% on SGLT2 inhibitors. But overall GDMT usage is only 28%. We did not do fantastically well there, but individual drugs were used quite a lot. And when we used our modified GDMT, that increased the percentage of patients to 28%. That's what happened. How are the beta blockers used? This is where bisoprolol scored. In heart failure, bisoprolol seems to be the drug of choice. In heart failure, predominantly 35% were on beta blockers, bisoprolol. Then carvedilol came in and metoprolol came in a third only. The other drugs like nebivolol and atenolol is also prescribed in occasional patients, but nearly 19% of patients were not on beta blockers. That is something very interesting that we found out. Now, India is a beautiful country, and India is very well known to be called as the country of paradoxes. India is the only country where you cannot kiss in public, but you're allowed to piss in public. This is the only country where you can do this. It's a beautiful paradoxical country. And everybody in India is always in a rush, but nobody comes on time. I think we are all used to this concept. This is how India works. And the biggest paradox is the coronary artery disease paradox. When it comes to coronary artery disease, Indians have a low level of LDL cholesterol. We have an LDL cholesterol which is 10 milligram lower. But if you start looking at coronary artery disease, it happens 10 years earlier. So unfortunately, we have a higher incidence of coronary artery disease in a younger age group. 25% of MIs actually happen in patients who are less than 40 years of age. 50% of deaths happen less than 50 years of age. So this is much, much more than what the Western population is seeing. So we are having younger patients with coronary artery disease, and we should be looking at what is the difference. The difference here is that we have what we call as the thin obese person. You are thin, but you have an abdominal obesity because your abdominal fat content or the visceral fat is high, which promotes inflammation, and it has been considered to be part of the metabolic syndrome, and they are more prone for coronary artery disease. And nowadays, we don't talk about the abdominal mass or the body mass index. The more recent thing is look at the waist-height ratio, which you need not correct for any ethnicity. Waist-height ratio of more than 0.5 is abnormal. Waist circumference height, 0.5. This is standardized for all the countries everywhere. And this has been found to be very, very useful. And this is going to be the future of metabolic syndrome also. There is an adipose tissue overflow. There is normal weight with dyslipidemia, severe insulin resistance. All these are factors that are known. And there is a distinct phenotype in India, less than 45 and more than 45. Less than 45, smokers are very high. 72% smokers. Look at what happens if it's more than 45, it's just 34%. But if you start looking at the vessel disease pattern, it's predominantly single vessel disease in the younger, while multi-vessel disease and all these genetic factors, and look at the conventional risk factors like diabetes and hypertension, they start going up in these patients. There is also a smoker's paradox. Smokers actually survive much better in coronary artery when you have a STEMI, because there seems to be a thrombotic component. Once you remove, they seem to be faring much, much better. Specifically, if you look at the Indian patients, these are all the peculiarities. Most of the patients actually have a silent ischemia, and the primary event of presentation seems to be an acute coronary event. Diffuse multivessel disease is very well known. All of us have seen plenty of that. There is a predominance of plaque rupture, increased thrombotic milieu, and increased platelet aggregation, all leading on to increased acute coronary events. Now, coming to what we did in Tamil Nadu, I should tell you something about what we are doing in Tamil Nadu. We have a registry for that. The ACERT STEMI registry is not yet published. I just looked at, for this particular talk today, I looked at the data. We found out that smoking was much less in our patients. Only 9.2% were smokers. Interestingly, the amount of diabetes was very high, 59%, much higher than the Indian registry so far. And hypertension was pretty much 50%, like what the other registries said. And across all the registries, diabetes is high, but smoking surprisingly was much less among our patients. What about the prevalence of the other rarer risk factors like dyslipidemia? Diagnosed dyslipidemia was very less, though actually it's very, very prevalent. We don't look at dyslipidemia. I think our preventive cardiology is doing very badly in these group of patients. When they were treated, I'll only focus on the beta blocker usage. If you look at the beta blockers, at discharge, only 50% of the patients in the Tamil Nadu registry are on beta blockers. Only 50%. This is the fact. And metoprolol was the biggest drug used, very close to bisoprolol, so more or less equal amount of bisoprolol and metoprolol. Some people use even carvedilol, and even nebivolol has been used in acute in a STEMI situation. Heart rate is a very, very important factor in coronary artery disease. Not only in coronary artery disease, if you start looking at chronic heart failure, comorbidities, remodeling, ischemia, atherosclerosis, everywhere heart rate today is spoken of as a risk marker. It's not a risk factor, it's a marker. So if your heart rate is high, already we have discussed that the heart rate is more than 80, there is going to be increased incidence of atrial fibrillation. And the European guidelines have come up and said that if your heart rate is more than 80, it is not going to be good for you. Centrally speaking, how do you reduce the heart rate? Beta blockers come into the picture. The entire spectrum, I told you, starting from the risk factors like hypertension, you start looking at coronary artery disease, heart failure, myocardial infarction, remodeling, enlargement. Till the patient dies, I think the patient should be on a beta blocker. I think this works everywhere. And in this continuum of diseases, the risk factors, structural changes, it helps benefits, coronary artery diseases benefits. Heart failure, we have seen plenty of these trials wherein it is useful across the board, and we should be looking at it. So finally, last slide that I'm going to talk to you about is in hypertension, you have an early hypertension clustering of diseases, and there are some peculiarities. The incidence seems to be rising quite a lot. Coronary artery disease, we have premature disease, malignant coronary artery disease, severe coronary artery disease with a high mortality. There is an Indian paradox where the thin people are still fat with an abdominal obesity. Heart failure, the demography also shows we have younger patients, worse prognosis, not adequately treated. So with this, I think we have an expert coming in today. Professor Ricardo Fontes Carvalho is here with us today. And I think it's a great pleasure to call him next to talk on beta blockers in 2026. Where do we stand in the paradigm? Thank you so much for the patient listening.
Check. Yes. Okay. We'll start here and then.
Okay. So, good evening, everybody. Namaste to all of you. Good evening to all the people here in the room, but also to our virtual audience, because we have a lot of people attending in the live transmission. So good evening to everybody also who are attending. So first of all, I would like to start by thanking to Mark for two things. First, for the opportunity to come here to India. Every time that I'm here, I'm very most welcomed by everybody. Everybody is really fantastic. And I've been having fantastic days here, sharing experiences, which will be the spirit of today, sharing clinical evidence, scientific evidence, guidelines, but how they can be applied to improve the management of our patients with cardiovascular disease. So this is the first reason that I would like to stress. The second reason is that we are always evolving in the field of cardiovascular medicine. So what is exciting when we discuss medicine in general, but cardiovascular disease, is because we are always with new trials, new scientific evidence, it's always important to discuss how we can better apply our scientific evidence to the management of our patients, which is the main objective of being all together today, which is if we can improve the management of our patients, which should be our objective. So I will discuss this topic with beta blockers in 2026. Where do they stand? And I would like to go through this latest scientific evidence, going to, let me just see if it is changing the slides. Okay. 1 minute, not yet. Go ahead. No, it will be working. Okay. So let me go through what will be the outline for today. So I will change from here so that we can be, yeah, can you put the mic? Yeah, so that we can be more closer and to discuss better. So what we will discuss today is new scientific evidence, clinical applicability. So I will go through 4 main parts in my presentation. So we will start by discussing how cardiovascular medicine is evolving with some trends in the management of our patients. Then we will go to this hot topic today, which is how we interpret the evidence regarding the use of beta blockers in coronary artery disease. Then we will go to heart failure with reduced ejection fraction. I am fortunate because the previous speaker also started by saying the importance, for instance, of the 4 pillars. And then we could not discuss beta blockers without going to some details regarding what the new guidelines of hypertension say about the role of beta blockers. So this will be what we'll be discussing in the next minutes over this presentation. So let's start with more general things, which I think are very exciting on how we are evolving regarding cardiovascular disease and cardiovascular management. And I will start by saying and by focusing on a positive message. This is a very nice article that was published about the 200 years of the New England Journal of Medicine, which shows us what we together, which are in the room, have managed to achieve when we talk about cardiovascular disease. And this has been a story of a fantastic success. So you see that across the last decades, with all the advances that have been happening in the management of cardiovascular disease, we were able to significantly improve the prognosis of our patients with cardiovascular disease. And this happened across the globe. And there are very few diseases which have managed to achieve what we can see in this slide. In 2 or 3 decades, we were able to reduce by 40% the age-adjusted mortality for cardiovascular disease. So this is a very important message, which is we together, if we treat well our patients, we have this concept nowadays that cardiovascular disease is mainly a preventable disease if you treat well the cardiovascular risk factors, but also it is a treatable disease if you do an early diagnosis and if you use all these technologies. So I think this is a very powerful message for all of us, which means that if we apply the scientific evidence that we will discuss to our patients, we will be able to significantly improve the management of our patients with cardiovascular disease. What is interesting to discuss is how we achieved this success story on the management of cardiovascular disease. Okay, we have new technologies, ICDs, we have TAVIs, we discussed this. They are very, very important. But what the data show us is a second important and powerful message, which is most of this improvement in the management of cardiovascular disease is something that we can give to all of our patients, which is managing well cardiovascular risk factors, doing what we call optimal medical therapy, because this is not only, but this is a main driver of success. And all of us in this room can improve patient prognosis by giving what we call the optimal medical therapy to our patients. The third message, which I think is evolving very fast and is something that we do every day in our clinical practice, is to individualize the therapy that we give to our patients. So more and more, we are not only treating the arteries or the sphygmomanometer, we are improving the way on how we understand each patient, how we diagnose each patient, and with this improvement in understanding what is happening, we will individualize the therapy. So, okay, guidelines are very important, but we will need to apply the guidelines to each patient that we have in front of us in this concept, which is individualizing patient therapy. And that is why we will always need physicians, doctors, and not computers or artificial intelligence to treat our patients, because we will need to, of course, to individualize therapy. The fourth, I would say, evolving trend when we discuss medicine in general, but especially cardiovascular disease, is this idea, which is, okay, when we try to apply scientific evidence to clinical practice, we have two main objectives. We will, of course, want to prolong survival, and we will discuss this about, for instance, in heart failure with reduced ejection fraction, but don't forget also that it is important to improve quality of life. So we, as doctors, will want the two things at the same time in our patients, which is giving more life, but also giving more quality of life to our patients. And we will see how this can be achieved, ideally using what we call nowadays the shared decision making, which is putting the patient with us together to have like a combination of efforts to improve the management of cardiovascular disease. So I would say that, okay, fantastic news. Although we have a lot of cardiovascular disease, but we have the power to transform the management of cardiovascular disease with these general concepts that are evolving. So what we will do in the next minutes is try to go into these very important diseases. We discussed the importance of coronary artery disease. We discussed the importance of heart failure and hypertension. So we will try to go one by one to see what is evolving and what is happening in changing the concepts and the paradigms of treating this disease. So let's start with what is happening in coronary artery disease. So the new guidelines, and both the American and European guidelines, introduced an evolving and changing the paradigm. So if you remember, previously we called this stable disease, stable angina, stable coronary artery disease. We know that this is not a stable disease because the patient can have an acute event when we don't know when it will happen. So the new guidelines introduce this concept, which is important for our practice, and also to say this to our patients, which is the concept of chronic coronary syndrome, which means, okay, this is not a stable disease, this will be a chronic disease, which will require lifelong management because events can occur at any time. So under this big umbrella of chronic coronary syndromes, you can have patients who don't have symptoms, but who have, for instance, coronary plaques. You have the patients, for instance, who had a previous myocardial infarction, who entered in this more chronic phase, but also the patients who have LV dysfunction due to coronary artery disease. So this is a big umbrella, I would say, where you have different patient profiles, but the principles of therapy will be more or less the same, as we will discuss in the next slides. So another thing which is evolving is this idea that if we have a chronic disease in a patient, we will need always this idea of chronic, the optimal medical therapy, and we need to look not only to the plaques, but to the patient as a whole. Don't forget, these patients frequently have not only coronary artery disease, they have peripheral disease. This is a systemic disease, which means that we will need also here, we use this concept first in heart failure, but nowadays we are also using this concept in coronary artery disease, which is also pillars of treatment. So all these patients will need, of course, antithrombotic therapy. We all know this can be aspirin or clopidogrel. For instance, nowadays there is a lot of new data showing that clopidogrel can be important also in these patients. We will need aggressive reductions in LDL. This is a main driver of long-term prognosis. As you are aware, in the new guidelines of hypertension, we are recommending lower targets to reduce blood pressure, but also management of obesity and diabetes. And don't forget, because all of this will improve prognosis, but don't forget that it is also important to improve quality of life, reduce angina symptoms, and this should be something that we should go also when we manage patients with coronary artery disease. So for this, there is no doubt that, and the guidelines say this very clearly, that to reduce symptoms of angina, to have the anti-ischemic drugs, you know that although a lot of agents can be used, the beta blockers are a cornerstone in controlling the symptoms of angina in our patients. And as you know, they can be used in these different clinical scenarios as recommended in the guidelines. I'm not going to all the details, but if you want in the discussion, we will have some time to discuss. But no doubt that beta blockers are a cornerstone in the management of angina in our patients with coronary artery disease. And these are the recommendations from the European Society of Cardiology, but the American guidelines say exactly the same, so I'm not going to enter into all the details. But the question is, okay, beta blockers, and we discussed this already, are they an homogeneous class of drugs? And the answer is clearly no. So we know that, for instance, ACE inhibitors or ARBs or even statins, they are a very homogeneous class of drugs. But when you talk about beta blockers, you know that you have all of these effects when you use beta blockers. But for cardiovascular disease management, we know that the beta-1 effect, the beta-1 blocking effect, is the main driver of the benefits of the beta blockers in cardiovascular disease. So we know that beta blockers is a very heterogeneous class of drugs. So you have non-selective, you have selective, you have different pharmacodynamic and pharmacokinetic profiles. And what I would like to stress and to reinforce is what has been said. So regarding the pharmacokinetic profile, you know that bisoprolol, you have this very important thing, which is the half-life, which makes makes it as a once daily administration. You have very stable doses and bioavailability, and also I will show you in a minute, the first pass in the liver. You almost don't have drug interactions, so no dose adjustment also in hepatic and renal disease, which is, I would say, an ideal profile to use in our patients with cardiovascular disease. So we have been showing, and these are a lot of data, showing that bisoprolol, for instance, has the lowest pharmacokinetic variability among all the beta blockers, which is also important for the predictability of effect. And a lot of data showing that because it is not dependent on this metabolism, you have this predictable effect, which is important in our clinical practice. And even in patients with receiving dialysis, as you know, you have a good profile also in these patients. So I would like to summarize in one slide, if we had to take one slide regarding the use of bisoprolol in our clinical practice, I would say 5 important messages. First, as you have seen, you have the benefit of having a very selective beta-1 blocking effect. Then you have a lot of data and trials. I'm not going to all the trials showing this, but you have an important and strong anti-ischemic effect. Then this is very important, and we were discussing this before entering the room, which is having drugs that are once daily administration. Don't forget, this will be frequently lifelong therapy, and regarding compliance and persistence on the long term with the therapy, once daily administration is really key. But then there are two other characteristics which are important. Don't forget that you have an excellent safety profile, even in the most severe patients with COPD. Last year it was published an important clinical trial which used bisoprolol in patients with COPD with at least 2 exacerbations, and it was an excellent safety profile. And also metabolically neutral effect, as you know, minimal effect in erectile dysfunction, and also minimal effect on peripheral artery disease. So this is important when we deal with our patients who have frequently several comorbidities and with a very good profile in terms of pharmacokinetics, but also clinical applicability. I'm not going to all the details of the studies because you probably know, but just to reinforce that a lot of studies have been done showing the benefits in stable coronary artery disease, in arrhythmias control, but also in acute coronary syndrome. So it is no surprise that in Europe, in the US, bisoprolol has been the beta blocker which is mostly used. And for instance, we were discussing this before entering here, 90 to 95% of my patients are treated with bisoprolol because of these clinical characteristics that I showed you, from not only a pharmacokinetic but also from a clinical point of view, which I think is important. So we discussed already several things. Let's go into some details because this is a hot topic nowadays, which is, okay, we have no doubts regarding the use of beta blockers for angina control, but as you probably heard, there is nowadays some controversy if beta blockers should be a lifelong therapy after a myocardial infarction. So what we will try to do is to summarize what is the latest scientific evidence. And why is this a hot topic? Because in the last year, it's fantastic how in 1 year we have 5 trials in the New England Journal of Medicine to address this issue. So what we will try to do in the next minutes is to summarize these clinical trials, but at the end, and more importantly, I will try to bring this scientific evidence to some clinical messages on how we can do in our patients in our clinical routine. So let's go one by one to see these 5 trials and to see what they showed and what they didn't show and what can be clinical messages. So this story started with this one, which was the first one which was published. So what they tried to do, I will summarize very briefly. So they used patients with previous myocardial infarction, patients with a preserved ejection fraction, and then they randomized these patients to beta blocker versus non-beta blocker after a myocardial infarction. Don't forget that these studies were randomized, but they were open label, and you will see some limitations of this kind of trials which were done mainly in Europe. Don't forget that almost all of these patients had to go to the cath lab, and almost all of these patients had to be revascularized regarding management, which is something important. Why? Because when we go to the real world, I would say, we don't have only these kind of patients. And we were discussing some minutes ago, for instance, here in India, it's very frequent the patients who have diffuse disease and who don't have only the single artery disease, which was what was included mainly in this kind of clinical trials. So this first trial showed that beta blocker or no beta blocker, the prognosis was more or less the same. And if you go to the details, I'm not going to enter all the details, but there was no significant difference in this first trial between the 2 strategies. But don't forget, and this is a limitation also of these open label trials, which was significant crossover. And they all show this. There is a significant crossover between the two arms when they do the beta blocker or no beta blocker strategy. Then we had a second trial, which was published just a few months after this one, which was called the ABIS clinical trial. So what this trial did was slightly different. So they had patients after myocardial infarction, and they were randomized to interrupt or no interruption of the beta blocker. So a lot of patients here, you can see the patient profile of the patients, and the patients had to be stable with no previous events in the previous 6 months. So what happened in this trial? When they interrupted the administration of the beta blocker, this was associated with an increased risk of hospitalization for a cardiovascular reason. So there was a sign that probably interrupting the beta blocker was associated with an increase of hospitalization for a cardiovascular reason. And what has been shown, and this is a sub-analysis of this trial, was that in the population who had hypertension from this trial, you see that interrupting the beta blocker will increase, of course, the blood pressure. It will increase by 10 beats per minute the heart rate. And this was associated with the increased risk of hospitalization, which was seen in this population in this trial. So here are some concerns regarding the interruption of the beta blocker. Then we had 2 other trials which were presented last September in the European Society of Cardiology. They were presented in the same session, which was interesting because in the same session we also had some contradictory signs. So first it was presented, this trial, which was done in Spain mainly, was the REBOOT trial. Again, a large population of patients. They were randomized to beta blocker versus no beta blocker. And here it was neutral in this trial. This first trial, it was neutral. Either strategy was associated with the same prognosis. As I said, at the same time, in the same session, another trial done in Northern Europe, which is called the DanBlock clinical trial, a similar design, okay, just for your information. And this, in this trial, there was a slightly increased risk of cardiovascular events with the non-taking beta blocker. So how can we summarize all this evidence, which is not easy? I'm not going to enter into all the details because these trials included different populations. They are not comparable. As we have seen, some are positive, some are less positive. What we can see from the comparison of the trials is that it is very difficult to compare different populations again. So we must interpret all this with some detail. But I would like to stress this message, which I think is important. Don't forget that this is a clinical trial, and this kind of population that was included was very different from what we see in real-world practice. For instance, if we compare these trials with the registries, you see that the patients in real world have much higher rate of events compared to these clinical trials, which means that these clinical trials included a subpopulation of patients after myocardial infarction who were very well treated, almost all of them received good revascularization strategies. And because of this, there is some, we need to interpret this. One thing is clinical trials, the other thing is the kind of patients who are on real world evidence, I would say. So let's go to the important thing. Okay, some confusion, some interesting things happening in science. Let's go to some practical things. Practical messages. These trials did not evaluate acute phase. So in acute phase of myocardial infarction, there is a strong recommendation that beta blocker should be used because it is very clear that in the acute phase, beta blockers reduce the risk of arrhythmias, and they should be used in the acute phase of myocardial infarction. So this is very clear. This is not information coming from these trials, but this is coming from previous evidence. Second thing, don't forget that these trials did not assess angina relief. Okay, so beta blockers are still and should continue to be first-line anti-angina medication because, don't forget, one thing is improving prognosis, quantity of life, other thing is improving quality of life, and this is also very important. Let's try to see what we can learn from these trials. What we have learned from these trials is there is still, it is mandatory to use in all patients after myocardial infarction who don't receive a complete revascularization, of course. It is important if the patient, of course, have angina. We learn from these trials, and I will show you the data, that if the ejection fraction is between 40 and 50%, there is a clear benefit of using the beta blocker. Where do we see this evidence? From this meta-analysis. This is an important meta-analysis where they joined all patients with an ejection fraction between 40 and 50%. And this population of patients, as you can see, they had a reduction of 25% on the risk of major adverse cardiovascular events. All patients who have arrhythmias, all patients who have uncontrolled hypertension, for all of these patients, we will, of course, need beta blocker as lifelong therapy as a clinical message. Okay, so we try to simplify a lot of these clinical trials, meta-analysis to our clinical practice. The two final topics that I would like to address in the next minutes is two important diseases. First, heart failure with reduced ejection fraction that we discussed already, and then we will just very briefly go into hypertension management and the role of beta blockers. Let me start with a fascinating disease, at least in my perspective, which is heart failure with reduced ejection fraction. And we will see the new paradigms of treating these patients with heart failure with reduced ejection fraction. When you look to the natural history of this disease, what we have seen is that we are diagnosing and treating heart failure with reduced ejection fraction too late in the natural history of disease. Usually, we are treating these patients in a very advanced phase. So what we are learning is that with strategies to improve diagnosis, to improve mass screening of heart failure by using, for instance, natriuretic peptides and more use of echocardiography, we are able to diagnose earlier the disease, and this will be important to improve the prognosis of our patients. And why is this important? Because, I don't know if you are aware of this, even a patient after a myocardial infarction who are very high risk, okay, they are very high risk, and we always say that a patient after an event is always very high risk. But if you compare the risk of an event of a patient with coronary artery disease compared with a patient with heart failure, you see how higher risk this population is. But what is the most important message is what I will show you in the two next slides, which is, again, and going to my previous slide, a message of hope in the management of these patients. 10 years ago, 15 years ago, sometimes these patients, we were a bit upset because the prognosis will always be bad. Nowadays, what we have seen is with the concept that has been said before of the 4 pillars of therapy, we can significantly improve the prognosis of our patients. But sometimes we don't imagine how much we can give to these patients. And I think this will be easier for you to understand in this analysis which was published. If you have a patient with heart failure, reduced ejection fraction, who is 55 years, if you use the 4 pillars of treatment in these patients, you will add to this patient life more 8 years of life. And if the patient is 65, you can add 6 years of life. And this is a very strong message even to communicate to the patient, which is, okay, you have this disease, okay, this disease is associated with a less good prognosis, but don't forget that it is, if you do the therapy well, you will significantly increase the number of years that you will live, with the number needed to treat for mortality of only 4, which is quite remarkable. So let me share with you one important thing, which is how we can apply nowadays the pillars of treatment in clinical practice, because the paradigm is evolving and is changing. So as you know, until now, we were used to do what we call the sequential therapy, which is starting with one pillar, then try to go into the maximum dose of that pillar, then introduce the second pillar. So this would sometimes take more than a year to have the 4 pillars in the maximum doses. So what is the new concept and the new paradigm of treating heart failure with reduced ejection fraction is that you should give to these patients at least, and the fastest as possible, a small dose of the 4 pillars of therapy. So what is nowadays recommended is that once you have a patient with heart failure with an ejection fraction below 40%, you should initiate, probably in most patients, of course you will individualize, but most patients should receive immediately the combination of the beta blocker with the SGLT2 inhibitor. What is the rationale? Don't forget that the beta blocker is, from the 4 pillars, the one which is associated with more reduction in total mortality, and the SGLT2 inhibitor, as you know, you have a decongestive effect in an early phase, which is good in this kind of patients. So this is a very strong message, which you have seen, for instance, in the CBIS trial, from the use of bisoprolol in heart failure with reduced ejection fraction. As you can see, there are very few therapies that can give to the patient a reduction of 30% in total mortality, which is quite remarkable. The second message, which I think is very important, is that when you treat patients with heart failure with reduced ejection fraction, sometimes with the use of the beta blocker, you don't achieve always the maximum dose. But the good message is that even if you, because you cannot increase the dose because the patient do not tolerate or because the heart rate starts to be too slow, the message which is good is that even if you only can achieve low doses, the benefit in terms of prognosis is still there, and this is also important for our practice. So if we have to summarize what is nowadays the evidence regarding the applicability, we have these 3 messages. We will individualize the order, but most of the patients start with the beta blocker and the SGLT2 inhibitor. Try to have the initiation versus the up titration. So the idea is to start the 4 pillars as soon as possible in the fastest way, because this is associated, as I showed you, with the most benefit in terms of reducing the mortality of these patients. So let's go and see the final summary slide. There is some noise in the back, some noise, too much noise is there, yeah. So let's see, to summarize what we have with bisoprolol in heart failure with reduced ejection fraction. Again, what we want, a selective beta-1 effect, because this is what drives the benefit in heart failure with reduced ejection fraction. I showed you the CBIS trial data showing a reduction in total mortality. Again, this is important, especially in patients who will do a lot of medication, of course, 4 pillars of therapy. And as we discussed, patients have significant comorbidities frequently and a good safety profile. But here, I think this is an important message, which is the flexibility of those. So you can use either 1.25, 2.5, 5 milligrams, which are associated with this benefit in prognosis. And this is important for the management of our patients with heart failure with reduced ejection fraction. So going to the end, and I will not go into all the details because the objective of this session was mainly to concentrate on the new data in coronary artery disease and to concentrate on heart failure with reduced ejection fraction. But of course, we could not talk about beta blockers without focusing also the management of hypertension. And here I would just summarize very briefly 3 or 4 messages from the new guidelines of hypertension that are nowadays available. First and foremost, don't forget that hypertension is the risk factor which most contribute to cardiovascular mortality. So this is a very important message regarding the importance of controlling blood pressure, because it will prevent coronary artery disease, it will prevent stroke, but also heart failure. So going to the guidelines, and just to bring, I would say, 4 messages to have more discussion when we go also to the discussion panel. So what do these guidelines say? I would say 4 or 5 things. First, this message which is very powerful, which is what is important in hypertension is to reduce blood pressure, because reducing blood pressure is what is associated with the improvement in cardiovascular events. So the guidelines say this very clearly. The guidelines also say that for the management of cardiovascular, for the reduction of blood pressure, you can use what we will see here, which is the classes of antihypertensive drugs. And of course, you will then individualize, and we go to this concept of individualizing the management according to the patient profile that you have. That's why, okay, it's important to reduce the blood pressure, but you will select the drugs according to the patient that you will have in front of you. So what the guidelines say is that all patients who have one of these clinical characteristics, here we have the individualization of the therapy, will need always a beta blocker, either as monotherapy or with combination. So we discussed very previously, for instance, in patients who have hypertension and a heart rate which is above 80, it means that probably these patients have sympathetic overdrive, so this is important to use. So you see the patient profile where we must need always a beta blocker, either, as I said, in monotherapy or in combination therapy, because this is also a concept which is not new, but it is reinforced in these guidelines. Don't forget that most of our patients with hypertension will need combination therapy. So there is a strong focus on these guidelines that most of our patients will need combination therapy to control the blood pressure. And we know that bisoprolol have a lot of data showing reduction in blood pressure. So going to what I was discussing, either using bisoprolol as monotherapy according to the patient that you have, or using bisoprolol in combination with other drugs, for instance, as we discussed previously, with telmisartan, which is an ARB with a very good efficacy and safety profile, with a lot of benefits across the cardiovascular continuum, either, as I said, monotherapy, combination with telmisartan with an ARB, or if you have a patient who will need, in this individualization, calcium channel blocker, you have here the possibility of, according to the patient profile that you have in front of you, combining or using the drug as you will need according to this concept of individualized therapy, if you want, and if you, according to the patient that you have, a combination with bisoprolol and amlodipine, which is associated with a significant reduction in blood pressure. So we will further discuss this probably in the discussion panel. So I will go, and we will be able to receive not only questions from you in the audience, but also in virtually in all these places that are together with us to this night. So I will go now to the take-home messages and the final messages. So I would say 3 simple things, 3 simple messages. First message is we have seen this. We have seen this in coronary artery disease. We have seen this in heart failure. I started with my first slide with this. We are able together, applying science guidelines to clinical practice, to significantly change the prognosis of our patients. Of course, with a great power to us, as physician, we have a greater responsibility, which is implementing this in our patients and in our clinical practice, which I think is an important message. Second message, and summing up, the topic was to discuss the role of beta blockers and bisoprolol in cardiovascular continuum. We showed a lot of data. We showed the benefits in hypertension. We discussed the management of patients with chronic coronary syndrome. We discussed in heart failure with reduced ejection fraction with this concept of flexibility in the use of this drug. And my final message, which is a very important message, which I would like to deliver. This was said by William Osler. As you know, probably William Osler was the father of what we call nowadays the modern medicine. And he usually said one thing that is very important to me as a doctor who sees a lot of patients and as a clinician. The good physician is the one who treats the disease, who looks to the coronary artery or just look to the ejection fraction or who only looks to the blood pressure. The great physician is the one who is able to treat the patient who has the disease. What I mean with this is this concept that we need to see the patient as a whole. We need to have the patient engaged in our discussions. And of course, we will have this power to improve the prognosis of our patients with cardiovascular disease. So thank you very much for your kind attention. I think we'll go now to the discussion panel, so we will put things in place. And we are happy to receive your questions, of course.
So good evening, everybody. Again, back, Dr. Harshal, and I just want to update that there are cue cards, question cards on your table. You can write the questions and pass it on to us, or we will circulate the mic also at the same time. But very interested and happy to share that we have almost 2,000 doctors attending across India this live event, which is broadcasted. Okay, so I'm just sharing, handing over the session back to Dr. YVC Reddy, sir, to take the proceedings there.
So we listened to two wonderful talks. Prabhakar brought this perspective of what we're dealing with in our country and in the local region, Tamil Nadu as well. Professor Ricardo's coverage of all the entire gamut of cardiovascular diseases, the role of bisoprolol was wonderful. I think we'll open the forum for discussions now, the most interesting part. But as you are coming up with the questions, let me start with the first question. We know that in heart failure, reduced ejection fraction, bisoprolol has taken over as the #1 beta blocker, in hypertension as well. But we heard that in coronary artery disease, ischemia and all that, many of us cardiologists use bisoprolol as the drug of choice, but we find that on the ground level, metoprolol seems to be being used by physicians due to some concerns. What do you think are the concerns? In your practice, in coronary artery disease, which beta blocker you use?
This is a good question because we were discussing this, which is some things are not rationally based, you know, some things are historical things. What I can say is that in our institution, in our hospital protocol, we use bisoprolol in 90% of our patients, even if they have coronary artery disease. So we try to introduce the bisoprolol in most patients in the first 24 hours, and then try to up-titrate even in patients with coronary artery disease. So I would say that there is no scientific rationale to be different in coronary artery disease compared with other diseases. That being said, remember one thing, which is something which is wrong. For instance, in heart failure with reduced ejection fraction, there is a lot of data showing that beta blockers can do harm if you don't use them correctly. What do I mean with this? As you know, the guidelines recommend that if the patient has reduced ejection fraction, there are only 3 beta blockers which are approved. On coronary artery disease, it is a bit broader, but in my practice, I use mostly bisoprolol as the beta blocker, which is mostly used in coronary artery disease also.
Is this something to do with the higher reduction of heart rate? The chronotropic effect seems to be more.
Actually, I don't see that too much in my clinical practice. I think this is a bit of, it is a question of historical reasons, which trials came first in the use, the first trial. Sometimes people adopt, and also because of historical reasons regarding the academic profile. You started using earlier metoprolol compared with bisoprolol, so for historical reasons, some things still stay. From a scientific point of view, I don't see such a clinical difference between the two drugs. And as I told you, we have a problem, which is metoprolol should be done twice a day. And I think, again, I go this and I see a lot of patients, compliance and persistence with therapy is very important. And I think we should go for every time that we can. Once daily administration is very important in our clinical practice.
So when we start talking about metoprolol, bisoprolol, nebivolol, carvedilol, all put together, they generally say 2 or 3 things. One is that if you want a better heart rate reduction, use bisoprolol. That's what the conventional discussion has been. And if you want a reduction in blood pressure, use carvedilol or nebivolol, which are vasodilatory beta blockers. Your comment on that?
I don't see this, okay? So, for instance, what I see is in the most severe patients, which is patients with heart failure with reduced ejection fraction, sometimes we even, when they have low blood pressure, sometimes we switch to bisoprolol because you have better control of heart rate with, in this population with so much reduction in blood pressure. So I would say that, as I said before, I'm very comfortable in most of my patients using this drug also, very importantly, because what I showed, we were discussing this, okay, which is very important is to know very well one drug in each class. I usually advise this, which is, okay, we as physicians don't know the details of every drug of every class because it's not possible. Okay, cardiologists know a lot of details about beta blockers, ACE inhibitors, some small differences. It is important that you choose a beta blocker you are comfortable with, that you can apply in several diseases, and which have this possibility of, as we showed, changing the dose easily. Reduce to 1.25 if needed, increase to 5 milligrams, sometimes 10 milligrams, according to the disease, according to the objective. I think this is very important, this flexibility of using this drug.
One question.
Your target heart rate and heart failure.
Good. This is good question. I try to have a heart rate of 60, okay? It's impossible to have exactly 60, but to have at least between 55 and 65. So what I try to do in my clinical practice is always try to push bisoprolol or the beta blocker before adding ivabradine, okay? Ivabradine is good because if we cannot go, and sometimes we see this, there are patients where we cannot go to maximum doses of beta blockers, but we should, because of the benefit in terms of mortality, try to have this heart rate around 60, which should be, I would say, the ideal heart rate of the patient.
Yes. Yes, please.
Prabhakar was talking about paradoxes in Indians. We have a very peculiar situation wherein the post-MI patients, all the time their blood pressure used to be less than, say, 100/70. So in the order of initiating 4 pillars, which one you will go first?
If the patient has heart failure or coronary artery disease?
Coronary artery disease, post-MI, I said. Post-MI.
Well, when the patient gets out of the hospital, I always try that the patient has the antithrombotic strategy, okay, which is, of course, very important. All patients need to get out with statins mostly. Nowadays, statins also with ezetimibe. Clear data showing it is important to start early. If the patient has any kind of LV dysfunction, also an ACE inhibitor or an ARB, which is important, the beta blocker, and then try to achieve the two other objectives. If the patient, nowadays, if it is obese, reducing obesity is also very important. If the patient has a LV dysfunction, probably an SGLT2 inhibitor will also be important. So here, I will not say that there is one before the other, okay? I would say that when the patient is discharged, it should go with all the medication that is needed for coronary artery disease, because during hospitalization, it is an opportunity to have all the medication that improve the prognosis of coronary artery disease.
Dr. Durai Rajesh, one question. In what percentage of patients do you expect a good drop in blood pressure and quite good rapidly with bisoprolol in a pure hypertensive patient?
I think this question is very difficult to answer, okay? Because, you know, hypertension, if you only look to the sphygmomanometer, you are losing what is the management of hypertension, because the patients have comorbidities. It is completely different if the patient comes with 200 versus if it comes with a lower blood pressure, comorbidities, etc. So I think there is no correct answer to this. In some patients, when it's well selected, you can have full control with monotherapy. In a lot of patients, we will need, as we discussed before, combination therapy. So
Ricardo has shown that slide where in good or big hypertension, usually a combination is not going to rely on one drug anyway.
Yeah.
So a combination is going to achieve that goal easily.
Two messages. I think he also said that whenever the heart rate is more than 80, there is an indication for a beta blocker, because 80 seems to be a cutoff where several studies have shown that benefit of beta blockers, reduction of heart rate is beneficial. So, and like he said, I think most of the patients are going to require a combination therapy. It's not which drug you're going to give, which two drugs you're going to give first.
What is your opinion on the use of bisoprolol in hypertension, pregnancy, first trimester?
you were discussing
We were
this before.
discussing this, yeah.
Hypertension?
Go ahead.
Pregnancy, first trimester, if beta blocker has to be used for hypertension, which beta blocker? Because conventionally, labetalol has
Labetalol.
been the drug of choice, because some data was there anecdotally, and then there's been no new data to surpass that. So we are using labetalol. But bisoprolol theoretically probably should be equally good and safer. Some small data suggesting that it's probably even safer than labetalol. But again, till those data come into the mainstream, I think most of us will be happy to continue labetalol in pregnancy.
Great.
The other question, what about heart failure reduced ejection fraction? Absolutely normal blood pressure, but the tachycardia is there. Can I use ivabradine directly without using beta blocker? This was a question from.
Yes, this is a good question. Don't forget one of the most important slides that I showed, which was the CBIS trial. The CBIS trial showed that if you use bisoprolol in a patient with heart failure with reduced ejection fraction, you reduce total mortality by almost 30%. That being said, is just to stress one important message, which is when you have a patient with heart failure with reduced ejection fraction, always start the beta blocker unless the patient is very congestive, of course. If the patient is very congestive, first we try to use diuretics to have a decongestive effect, wait 1 or 2 weeks, and then start the beta blocker. So to say what I was going to say and to answer more directly this question, which is we should start with low doses, okay, even if it is only 1.25, because beta blocker reduces total mortality and ivabradine can be used, but it does not have such a strong effect on total mortality. So try to focus first in the introduction of beta blocker, if possible, try to up titrate, and if it is not possible, then add ivabradine.
Hari, for you.
Yes.
Yeah, Ricardo has shown one slide on COPD and beta blocker. bisoprolol seems to be very well tolerated in this group. In our country, a lot of patients do get recurrent frequent chest infections.
Yes, sir.
So what is your experience?
I tend
Which beta
to,
blocker?
I tend to, just take it as it comes. For example, some people very wheezy and things like that. Sometimes it's very difficult for us to continue a beta blocker. But usually on a stable patient, I don't think with good supervision, I think beta blocker should be continued actually. That's what I tend to do. And a highly selective beta blocker like a bisoprolol would be probably the first alternative for me.
See, in fact, this question we are discussing, what beta blocker we use in our practice. He said 95%. I also agree with that.
For me,
The
99.
99. The reason is, it is one drug a physician can just prescribe the patient and you know that the effect is predictable. With metoprolol, because of the so-called first pass effect, a 25 milligram metoprolol suddenly can push the patient into severe brady, or a 200 mg might not work at all. So this variation in the efficacy of the dose, unpredictability, is very, very unnerving for the physician. For the physician wants a predictable response. The second is health status of the patient is dynamic. 1 month later, he gets a chest infection, wheezing, and if he's on relatively non-selective drug like a metoprolol, compared to bisoprolol, the wheezing might be a really troublesome thing, and you might be pushing the patient into new problems. So in that way, I think bisoprolol is a good drug to act to start with, metabolically very neutral, and in most of the comorbidities, it can be given very, very safely.
Yes, definitely.
Actually, what I do is I interact a lot with the pulmonologists there. So I do have pulmonologists who look at their lung function tests, and if they find that there is push them on maximum therapy and still not improving, then we try to reduce the bisoprolol. You go on a case by case basis. It is generally safe, but in that case, there is always ivabradine if you want to reduce the heart rate.
And,
I can add one other thing, because I showed in my presentation, but I did not show the clinical trial, just focus on the reference. If you go to JAMA 2024, there is a big clinical trial. Remember, JAMA is one of the most important journals that we have, which directly start in patients with COPD with at least 2 exacerbations in the previous year. They randomize the patients to bisoprolol versus placebo. And it completely shows that even in these very severe patients with COPD, bisoprolol was with a neutral effect, completely safe profile. So this is a very strong message, which is different from what was our reality 5 or 10 years ago. Sometimes we said, oh, don't use beta blockers in these patients. It is true if the beta blocker is not selective. With the beta-1 selective beta blocker, as I showed you, like bisoprolol, we don't see any kind of problems, even in those most severe patients with COPD.
Another question is on how early can we start beta blocker in acute MI? Inferior MI, of course, they are not mentioned. Imagine it is an antival MI. How early can you start a beta blocker?
I can share my practice. What we try in our patient, in our institution protocol is, unless the patient is in cardiogenic shock, unless the patient has very low blood pressure or any kind of AV block, this kind of situations, we start the beta blocker in the first 24 hours. So this is what we do in our clinical practice. It is like the institution protocol to start the beta blocker early because of it's according to the guidelines.
We follow the same practice.
We also follow this.
Yeah, I think.
Then about the SGLT2 inhibitors and beta blockers. You have interesting last slide. If you have to start a patient on HFrEF, borderline hemodynamics, this is the first 2 drugs you can start on. In fact, many of the patients with HFrEF, many of the time when they come in, they might be having alkylatemia, azotemia, creatinine might be slightly high. These 2 drugs you can easily start. So that is a very good suggestion now. What are the other benefits of starting these 2 drugs together?
Well,
as a first step.
Yeah, as I told you before, don't forget again, beta blocker in heart failure with reduced ejection fraction is associated with a strong reduction in total mortality. So there is this idea that with such a drug who has an early effect in reduction of total mortality, we should start as soon as possible. This does not mean that we will start in all patients the beta blocker. As I said before, if the patient has too much edema, we will not start the beta blocker. We will start with the diuretics and then start with the beta blocker. The SGLT2 inhibitor, why it is a drug that we initiate in an early phase? Mainly because of the two reasons. Because you have, especially in the early phase, a small decongestive effect. So, and this effect happens in the first days of treatment, which is also this idea of having an early effect. But also, we now understand that this is also important. You know that when you start an ARNI or spironolactone, you have some patients have hyperkalemia. What we now know is that the SGLT2 inhibitor reduces the risk of hyperkalemia when you introduce the other classes. We sometimes call the SGLT2 inhibitor a facilitator drug, which means it facilitates later the introduction of spironolactone or of the ARNI. So these are the reasons why, okay, we need to individualize to each patient, but as a general rule, nowadays we go to this idea to start in an early phase beta blocker with the SGLT2 inhibitor.
It's very important to start SGLT2 quite early, hemodynamically quite tolerant, unlike the ARNIs or beta blockers. So it is a very good role. Metabolic effects are there, apart from the mechanistic preload, afterload reductions as well. And beta blockers are important as well. You can start them at a very low dose and then keep up titrating. An interesting question. What about dextrocardia? Can we give beta blockers? So Hari, what do you think?
I don't think that doesn't make any difference here.
Right or left, beta blockers are the way to go.
Right or left? Sir, for the SGLT2 inhibitors, what about somebody with a urinary catheter, indwelling urinary catheter? Often I find it difficult when somebody has an, to start a DAPA and empagliflozin. They could be prone for urinary tract infections. Do you wait for them to be the catheter to come out before starting them on SGLT2? What's your routine practice?
I don't prevent the patient on a catheter from using SGLT2 inhibitors. But if there is any evidence of infection, yes, we have to stop it.
Okay, so I tend to be a little careful. Do you have any bad...
reason why I do that, I'll tell you the reason. The reason is these genital infections are mainly for patients who are not on catheters. And then the glycosuria is the one when they're not cleaning up, the infections are bound to happen. When a catheter is there, that problem is not an issue. So the reason why genital infections are happening is totally different. So indwelling catheter probably prevents that aspect.
Professor Ricardo, I have a question on this.
Sure.
Is there any data on this?
On
a
patients with catheter? As far as I know, there is no data regarding this.
So.
But
it's a personal preference.
No, but just tell me, let me just say one thing, which is SGLT2 inhibitors are mainly associated with genital infections, which is slightly different with urinary infections. As he said very well, this is associated with glycosuria, which increases the risk of having fungal infections. So I would say that even in patients with catheter, you should still using SGLT2 inhibitors. By the way, even in those patients who develop either genital or urinary tract infections, there is still a strong prognosis benefit of using the SGLT2 inhibitor. So what I say to my patients is always this. Okay, you had this thing, which is sometimes is very uncomfortable, either for men or for the women. But I always tell them, don't forget, the main disease that you have is the heart disease. And this is the important thing that you need to take care of. So I think this is important.
You need to be alive at the end of the day.
One more interesting question again. An obese, sleep apnea, hypertension, and he's taking already bisoprolol, and I want to start him on Mounjaro or semaglutides, etc. Can we co-prescribe semaglutides, Mounjaros with bisoprolol?
Yes, for sure.
I don't think there are any incongruence between that, and both are equally good. You can combine them. There's no harm in them. Yes. So obesity management with these two drugs, especially in patients with cardiac disease, is a very important advancement, and the beta blocker can continue along with that as no contraindication. Can the beta blocker stat dose be given with a loading dose in acute MI? When the patient comes with a primary for an acute ST elevation MI, you are giving the loading doses of statin, DAPT. Can we give a beta blocker also at that point of time? Yes, if the pressures are high, if the tachycardia is there, you can give oral beta blockers. Once upon a time, IV betoprolol was strategy was there. Nowadays, we don't follow that. Oral beta blockers can be given unless you are suspecting an infibol MI or lower heart rates, or you are anticipating an AV conduction block, or there is an impending cardiogenic shock, as Professor Ricardo has suggested. So otherwise, yes, you can. A low dose. Regarding the stopping of this interruption, he has brought about one interesting question, the controversies. Every MI, whether the heart failure is evident or only a silent LV dysfunction, you need to give beta blockers in these patients. But beyond 1 year, if it's very, very stable, completely revascularized, no residual CAD at all, LV function is perfectly normal, no hypertension, maybe there's a small group of patients beyond 1 year where you think that beta blocker may be down titrated or maybe taken out, but those are a very minority in our practice. So practically, most of the CAD patients will continue to get the beta blocker, like HFrEF. They might improve, the EF might become normal, but we're not going to reduce the beta blocker, because the moment you do that, again, you are putting the patient at jeopardy of recurrence of aggressive HFrEF.
I'll add one point to that. I think probably you'll have to look at the heart rate also there. If the heart rate is probably going to be more than 75, 80, again, you don't reduce the beta blockers. Why do you want to do that? There is a benefit of lower heart rate.
I think that the point is that don't try to remove the beta blocker just because the patient is stable.
Yes, sir.
In acute decompensated heart failure, very important subset. Patients do come suddenly with heart failure. He was already getting bisoprolol. He was on 5 milligram once daily before. What do you do in the acute stage? He's in florid pulmonary edema now. How do you manage?
So this is a situation where you have to be very careful. Actually, don't think about guideline-based medical therapy here. You have to diuresis the patient first, get them off. For example, they might be on inotropes, they might be on florid pulmonary edema. So diuretics are the key there actually. And then you have to just make them euvolemic like Prof was telling, and then you have to then go for guideline-based medical therapy actually. So
Are you going to stop it totally or down titrate and then continue a little? How do you do that?
somebody is it present, it depends on the situation. For example, somebody is acutely presenting naive, then you probably don't go on guideline-based medical therapy then. But somebody is already on it, then there's always a chance you could side by side simultaneously, you could, give IV diuretics at the same time, might be down titrate or continue on guideline-based medical therapy.
So technically what we say is that if you get an acute decompensation, your blood pressure is holding good, you just diurese the patient, he's going to be all right. Unless the patient is in shock and is going to require inotropic supports, you really don't have to withdraw the beta blockers. Like I think Hari made a very good point and said that if the patient is de novo, you decongest them first before starting the beta blocker. I think both are two separate subsets. I think we should not mix up patient naive, beta blocker naive and beta blocker already on slightly different.
Individualize the treatment, use clinical judgment. One interesting question again, what is the ideal time to take bisoprolol? Is once a day? Is there a chronopharmacology? Is there a particular time where it acts better? As I know, no special time benefits.
No, I would say no special, but I use in almost all my patients in the morning. Why? Because we want the greatest effect when the patient
Sympathetic
has more sympathetic activity, which is during the day and not during the night. In very special patients, sometimes when I try to push the maximum doses of beta blocker in heart failure with reduced ejection fraction, sometimes I do like 1.25 in the morning and 1.25 in the evening. But this is like very few patients where I try to push the dose, but it is associated with reduction of blood pressure. But I would say that what is recommended is to have early morning administration.
I use another strategy also. Like if the patient is low pressures, I give the ARNI in the morning and give the beta blocker in the afternoon.
A lot of time.
So all these different strategies. I think you have to individualize your patient.
I had only one
This is
patient
very frequent.
in my 35 years of practice, one patient who said that when he took bisoprolol at bedtime, he had nightmares. And in the morning, he is very happy. So probably that is one more reason we should give it in the morning. So this is an interesting clinical scenario. 75-year-old male, CKD, EF 25%, on dialysis. He is on beta blocker. Again, we could be on several types of beta blockers, but the general consensus nowadays, if patient is undergoing dialysis, we are shifting the beta blocker to bisoprolol. What are your comments on dialysability and the on and off effect?
No, I showed the slide. Okay, so I didn't have time to go into all the details, but I agree with what you said. The clinical message is what you said. If the patient is in hemodialysis, beta blocker that should be used should be bisoprolol because of the data that I showed. Yeah.
The other drugs which are dialysable, they can have an on-off effect. The dialysis, suddenly the drug effect will go off and then again the rebounds. So I think better to go in for bisoprolol in this.
Two other drugs that are okay are carvedilol and nebivolol. So in case the patient is already on that, you should remember these two also are reasonably good with dialysis. But generally what is preferred is bisoprolol.
Pure anxiety with hypertension, severe anxiety, which beta blocker, bisoprolol or propranolol? This is the question.
Yeah, this is a good question. I would say that if the patient is hypertensive, still keep with a beta-1 selective drug. But to control anxiety, we see this, that sometimes propranolol, it decreases the anxiety effect. See, some people even take it before presentations when they speak in public. So.
Or sit next to Professor Ricardo and try to talk before him.
I use bisoprolol in this scenario also. It's not uncommon clinical scenario. Youngsters with severe hypertension and severe anxiety as well. I use bisoprolol for this and also use my charm for controlling the anxiety.
What about in thyrotoxicosis? For example, newly diagnosed thyroid.
Question as well.
Yeah. So, for example,
Comments on that?
is it? I continue on bisoprolol, but some people switch over to propranolol. Actually, is that something you would do?
I personally use bisoprolol in all our thyrotoxic patients who are going for thyroid surgery also. For me, that's a drug of choice. The only extremely rare areas where I don't use bisoprolol, we were discussing over the tea there, is severe peripheral arterial disease is one. The other is probable pheochromocytoma, where you don't want to use a very selective beta blocker. And maybe extremely rare if the patient complains of severe nightmares on taking bisoprolol. In fact, other beta blockers can cause more problems. This is extremely rare. Hyperthyroidism, propranolol. Propranolol is used for migraine, anxiety, tremors as a tested drug for a long time. But in a patient with hypertension with all these effects, probably I think bisoprolol should be the drug of choice and you can treat anxiety separately. What is your comment on that?
I think it is correct to use propranolol if the patient has hyperthyroidism, and I also use in this kind of situation. Also, when the patient has tremor, yeah. Why? Because again, the propranolol has other effects beyond the beta-1 selectivity. So
CNS effects.
yeah, so when they have this kind of tremor, it helps in this disease. But again, these are very small situations. Yeah. Yeah. Very true.
Yeah, anyway, see, these rare indications we're discussing, I think probably account to very minority of our indications. In my personal practice, ours is a very aggressive unit of thyroid surgeries. And when they come for a referral with thyrotoxicosis going for surgeries as well, I personally use only bisoprolol. Yes. Again, there's a small data that probably the hepatologists would like in a chronic cirrhotic liver disease. There's some data that carvedilol might be superior. There again, a very small subset of patients, probably you can follow their evidence. Yes. Yeah. So in that scenario, yes, carvedilol may be useful. I think we had a very extensive discussion as well. Interesting questions. Ricardo's talk was excellent. Prabhakar showed the local perspective. I think every one of us is enlightened and more confident that bisoprolol is a drug to go as a first choice. Rare scenarios we have discussed along in the interaction where other drugs might be useful. But I think as a drug to go beta blocker, where you can start it with the confidence that the dose is going to give the predictable effect and you're not going to get any surprises, I think the drug to go. And we also covered up the latest evidences in the field, and it was a wonderful beta blocker summit. Thank you. Thank you, all of you. Thank you.
I am absolutely awestruck with the kind of scientific discussion which has happened right away. The energy is still rolling out here. So without taking much time, I just would like to say that some good things should not end. But we would have a very formal vote of thanks from Raghavanji. And one thing that we are standing in April, and it has been an August gathering, both live and at the Hybrid Center. So thank you from the bottom of my heart, and to all the webinar audience who's joined us live. Thank you so much, and over to Raghavanji for the vote of thanks.
I'll not take much time, and many of the doctors here know me. I am with Merck for 39 years, and I launched Conquer. When it was launched, it was only hypertension as an indication. Then in heart failure, when the indication was there after CB's Merit of Copernicus, we took it as an indication for heart failure also. Then we introduced 2.5. But only thing is, when we introduced Conquer, it was 14 rupees. Atenolol was only 1 rupee per tablet. So we could not compete with that. But later on, when we reduced the price, we became competitive. And what we found was Dr. YVC Reddy was also telling regarding this viral infection. I will tell only one instance. I will not take much time. We formed a cardiac division in 2009. Until that time, last priority was Conquer. We had all vitamins to be promoted more. So Conquer was the least earning drugs for us. But when we formed a cardiac division, Conquer became flagship. At that time, it took almost 12 years from 2009 to almost 2015 to reach 100 crores. But what happened is COVID, fortunately or unfortunately, gave a good support for Conquer business because of its lung-friendly nature. Many doctors who could not uptitrate beta blockers, especially during viral strains of COVID, they could use bisoprolol as an alternate, which gave a lot of increased prescriptions. And those patients who could not tolerate. Now also we find viral infection staying for more than 15 days, 1 month. The wheezing is there in the patients. When they have lesser selective beta blocker, there is a tendency they don't tolerate much with this lesser selective. So doctors do shift. We find a lot of shift happen, which has made in these 4 years, Conquer from 100 crores to reach 500 crores. This has opened the eyes of all the companies. 50, 60 brands of bisoprolol is available now. All metoprolol companies have launched bisoprolol. They say bisoprolol is better than metoprolol. So exactly, sir. That is because that I will just add only 1 second, as Dr. Prabhakar said. We did a survey across the country to find what is the difference between generic and bisoprolol, Conquer. We found that tolerability was good, efficacy was good. More than that, the pulmonary ventilation in generics was deteriorating over a period of 12 weeks than that of Conquer. That was more suitable. Other thing is we still import the raw materials from Switzerland because we tablet and export to other Asian countries here. So we have to comply with the USP standards, where all the generics imported from China, which is 1/10 the price of the raw materials what we get from Switzerland. That is why Conquer is better. And we did the survey, and clinicians told only one thing which Conquer scores over other generic is the availability throughout. We write generic also, we get only Conquer. So thanks a lot, doctor, for your trust and faith. So I'll not be between your fellowship and dinner. Big thanks to the August audience in person as well as digital. We have 2,500 doctors across the country listening to these experts from here. I start with thanking Professor Ricardo. Thanks, sir. Your first stint was in Delhi, 250, which was not webcasted. Second was in Hyderabad, which was 160, which was not webcasted. The only webcast is done from Chennai. So we are fortunate to have Dr. YVC Reddy here moderating the session. Well, big thank you, sir. And yeah, many doctors have selected this place as a venue. I thank Dr. Prabhakar for really helping us out, sir, in being a panelist and as a speaker, gave the Indian perspective of various cardiovascular disorders. Dr. Harikrishnan, sir, big thanks to you, sir. And he is more of a European in practice. So he is a big fan of bisoprolol. Big thanks to you, sir. Thanks a lot. Let us join for fellowship and dinner. Thanks a lot, doctors.
Batting